Shall I close my
If
sharing?
you can stop sharing, that is fine. Otherwise,
I'll stop it.
Yeah,
I'll
that
stop.
will be great. Good evening, everyone. Once again, welcome back. Myself, Dr. Neeraj Gupta, on behalf of IAP Allergy and Applied Immunology chapter, would once again like to invite you to this third episode of Allergen Immunotherapy webinar series. We have started this series with a high note on demystifying allergen immunotherapy, in which we discussed about the basics of immunotherapy and simultaneously that who is the right person and when it should be started and when it need not to be started. Then in the second episode, we discussed that which modality of immunotherapy is the right modality in the current scenario and what are the investigations which we need to follow. Now, after discussing so many aspects, still there is very important thing that whatever we have learned, let us now come to the clinical side. Let us come to the bedside. That whatever we have actually learned on the bench, let's apply it on the bed. So today is a very important day, and I will say that in this webinar series, today is the most important day and most important topic in which we'll be discussing about making allergen immunotherapy work, protocols to practice, which is actually considered to be, I will say that you can say like the need for which we have actually built up for the previous two sessions. And we have an excellent faculty today with Dr. Nagendra Prasad Komrala sir. He himself is like an institution. He will be formally introduced by my colleague, Dr. Sinchana. And then we will be having Dr. Deepthi Pujari and then Dr. Narmada Ashok. So all will be reflecting that how we can actually put everything into practice. And without much delay, let me invite Dr. Sinchana Bhatt, who will be moderating today. So she is a dear friend. She is the respected EB member, executive board member for the Central IAP Allergy and Applied Immunology chapter. She is a leading pediatric allergist from Mangalore. So Dr. Sinchana, you are very well welcomed. Please start.
Thank you, sir. Thank you, Neeraj sir, for that kind introduction. And I'm extremely happy to be a part of this program and moderating this session of making AIT work from protocols to practice. Like sir said, it's a most important part of this webinar series, and I'm very happy that our chapter is conducting this for benefiting all the pediatricians and allergists across India and world. So for the first session today, we have none other than, as sir introduced, Dr. Nagendra Prasad sir, Komrala sir from Bangalore. Sir is a senior allergy specialist and he's an institution in himself, like sir told. And sir is the founder director of Bangalore Allergen Center in Jayanagar in Bangalore. And he runs fellowship courses there as well as and has trained many allergists in India and abroad. And sir is well known throughout this allergy circle and otherwise also he's a very famous allergist and a great academician and orator. And we love to listen to him always and a very humble person. I welcome you, sir. And the talk for today would be from vials to victory. And we are very eager to listen to you, sir.
Yes. Thank you very much, Dr. Sinchana Bhatt, for your nice wording. And also Dr. Neeraj Gupta, which he has taken a lot of efforts to make these seminars working online. And I'm not taking much time. I want to share the slides. Shall I go ahead, Dr. Sinchana Bhatt?
Yes, sir, you can share the slides, sir. Yes, sir.
The title of today's
sir.
talk is From Vials to the Clinical Victory. The meaning is the optimizing allergen extracts and the protocols. I'll be touching only on the allergen extracts. The main points for today's discussion is the raw material collection and preparation, extraction of allergen for purified raw material with purification, protein quantification and standardization, quality control with the confirmation of major and minor allergen presence, molecular characterization of allergen extract, and chemical and physical modification of allergens. What is this definition of vials to clinical victory? Vials to transformative journey in allergen immunotherapy from preparation of allergen extract in vials through optimization and precision dosing to the ultimate clinical victory is the improved patient outcome, disease modification, and enhanced quality of life. It is also encapsulates the evolution of allergen immunotherapy, highlighting how advancement in extract standardization, delivery protocols, and a patient monitoring turn the simple vial into a powerful tool for transforming allergic diseases from chronic suffering to controlled or even symptom-free conditions with enhanced quality of life. There is one institute called Paul Ehrlich Institute, which is PEI, which is based at Germany, Langen, and is a competent authority for allergens, and it reports to the Federal Ministry of Health, and it works on allergens for allergy diagnostics and therapy. We have one more institute in Germany. In February 1981, the Allergen Standardization Subcommittee of the International Union of Immunological Societies, we commonly call IUIS, prepared the task of ultimate preparing standards that could be used by manufacturers and control authorities. The main goal of this subcommittee: generate and make available to investigators, manufacturers, and control authorities allergen reference preparations with assigned arbitrary international units, standards, and reagents. Allergenic activity of the composition content of important allergenic molecules. So the main theme of this is in the form of vials. That vials having allergen extracts, standardization, stability. The victory is a symptom reduction, reduced medication need, and an improved quality. To do this, you should have a protocol on dosing strategies, route of administration, safety monitoring. Allergen extract preparations of an allergen obtained by extraction of the active constituents from animal or vegetable substance with a suitable menstruum. For allergen immunotherapy products, may be unmodified vaccines or vaccines modified chemically and or by adsorption onto different carriers. Maybe aqueous vaccines, depot and modified vaccines, mixtures of allergen vaccines, and recombinant allergen vaccines. In-house allergen extract preparation. The allergen extract preparation is a foundational step for any allergy clinic or a research lab aiming for precision, cost efficiency, and a control over quality. Optimizing allergen extract is crucial for improving both diagnostic accuracy and therapeutic efficacy, especially in allergy testing and immunotherapy. In-house allergen extract preparation, we shall discuss about the methods, standardization, storage, shelf life, and a potency and standardization, biological unit, protein content, and allergenic activity. We have diagnostic extracts, which is commonly used for skin prick testing or nasal or conjunctival challenge test. Therapeutic extract, commonly used for subcutaneous immunotherapy kit, sublingual slit, or intralymphatic immunotherapy islet. It may be in the form of drops, tablets, compressed or lyophilized, or a vacuum-dried strip. Regulatory and quality control aspects, good manufacturing, GMP, batch testing, endotoxin levels. The first one, more important, is selection of relevant allergens to extract and use based on environmental exposure and patient sensitization patterns. So you should have a field study. What are the common aeroallergens which is found within the subject and exposure to the surrounding. Environmental relevance, like source type, what to consider is pollens. Commonly we have trees, grasses, weeds, common in subject's local region, which has to be found from the pollen calendars, which is already published in India. And a fungi indoor may be Aspergillus penicillium, or a outdoor maybe Alternaria, house dust mites in the humid regions, which are having more than 55%. Dermatophagitis tyrannosinus, Dermatophagitis farinae, Abdomia tropicalis. Animal dander, pet exposure like cat, cat, dog, cow, sheep, rodent, which is very common in villages in India. Cockroach, urban indoor allergens, Blatella germanica, or Periplaneta americana. So, and also we have another insects like moth and mosquitoes, which is also very, very common, which is inducing the allergen sensitivity among the children. Storage grains like farmers, rural homes, rice, wheat, maize, and pulses. Now coming on to the raw material, one is the collection. The timing of the collection of the pollen is very, very crucial. And it is always collected in the early in the morning before the insects flying across the plants. Because once the flies are flying across the plants, they will be contaminating the pollens. So you had to be very careful in collecting the plant pollens, and you should be not flowered, you should be not bud in between that is about to bloom. That particular inflorescence are very, very crucial. And a source pollen is gathered from various sources like trees, grass, and weeds. Purity is very important, and a pollen is checked for purity and samples with high levels of contamination as discarded debris permitted up to 0.5 to 1%. Now, after collection, it has to be dried. So the moisture content of the flowers has to be reduced. And once it is reduced, it becomes fragile, and you can make it into fine powder. Then you have to sieve it. Dried pollen is passed through a sieves. It may be depending upon the size of the pollen. It may be sieved through 300, 400 mesh, and to separate it from a large debris and other plant material. And all these pollens are having a fat content, and it has to be defatted. The fat has to be removed from the raw material. And usually we use acetone or ethyl ether to remove the lipids, which is always interfered with the extraction process and a therapeutic process. So as I said, the identification, that is authentication, that is you should be very familiar with that particular pollen of a particular plant, and you should have a correct species identification. So the palynologists from the botany, they could able to assist you, and they will monitor these pollens whether contamination is there or not. And to avoid the contamination, the moment you collect the inflorescence, you have to wash the material. Filter dust of mite, fungal spores can be removed by washing and dusting. Then coming on to the extraction. The common buffer which is used either is a phosphate buffer saline, we call it commonly PBS, or ammonium bicarbonate, which is having a fair pH of 7.2 to 7.6 to extract the allergen protein. Ratio typically we use either 1 in 10 to 1 in 20 weight by volume. That is, example is 1 gram of material in 10 or 20 ml of buffer. And usually it is done, extraction is done for 4 to 6 hours at 4 degrees centigrade with a constant stirring. So as I said, the pollen is extracted in a buffer for a specific time with a stirred cell by continuous stirring, which I will be showing the figure, or by dialysis. Usually this is a earlier period, they were using a cellulose dialysis bag, and which has to be In the bag will be inserted with the allergen extract and tied up on both the sides and kept in the saline and allowed to stir with the magnetic stirrer. So this is how this is done. And after that, a centrifuge of it has to be clarification, that is dust particles and all precipitate particles has to be removed by centrifuge at 13,000 to 15,000 RPM to separate the pollen debris and insoluble material from the extract allergens. Then lastly, the filtration, the supernatant liquid portion is taken out, is filtered through a membrane called filter, and we use a pre-filter called 0.44 micron to remove the remaining particulate matter and 0.22 micron membrane to remove microorganisms. That is, we call it as cold sterilization. Preservation, add 50% of glycerol, that is 0.3 to 0.5% for storage in diagnostic SPT. And the final pollen extract is freeze-dried and stored at a low temperature, -20 to -70 degrees, to maintain the stability and activity for a longer period. So what are the interfering substances in the extract? Commonly the lipids, protease, nucleic acids, polysaccharides, and salts. This is the one I told you about, the dialysis bag. It has got its own molecular weight of particular weightage, whatever you want. But usually we take about 5,000 kD cut-off tube, and we had to put a clip on the one side and store the liquid, and then again another clip has to be added, and it is allowed to stir in the magnetic stirrer, and slowly you can see that figure. One is on the left, which is loaded, and on the right, you can see that equilibrium is almost the content, the salt content of the allergen extract, which is diffused out into the beaker. So this is a schematic presentation which is shown, what I have shown in the dialysis bag. Now the latest one is the Amicon stirred cell, which is much more superior than the dialysis, which is happens to be a crude method. And here we have got a membrane of a different capacity, so that we can put the membrane, a polymer grade, which is about 5,000 kD, and which can remove all the particles below 5,000 kD. Why we are removing the 5,000 kD molecule is most of the toxic materials will be there. And what we wanted for allergenic, immunogenic activity allergens, which is above 5,000 up to the 70,000, sometimes 100,000 in some of the pollens and allergens. Then we subject to the chromatography, affinity chromatography. You see the red spots you can see, they are called protein recognized by antibody. So antibody is binding, and the protein not recognized by antibody, which is in the blue color. So you can wash a couple of times, then elute with pH 3 buffer, where you will get all the allergens, that is protein recognized by the antibodies will come out. That is more important than with the blue color. So to separate that, this is a microparticle, which is a microprocess, which has to be done with a chromatography. We have another new generation chromatography, which is a medium with a cellulose and polyacrylamide, that the protein of insert is displaying affinity for its ligand, becomes bound and immobilized by itself. That's what I have shown in the figure. It can remove from a contaminating proteins in the matrix mixture by simple means such as filtration and washing the matrix. Finally, the protein is dissociated or eluted from the matrix by addition of high concentration of pre-ligand solution. The purification relies on the biological specificity of the protein of interest. So this is a new generation chromatography, and you can see the middle aliquots, which is collected the extract what you want, and you can monitor on the screen the particular spikes which has been generated, and that proteins are more important. That is called the spike proteins, and which is very, very crucial for allergenic activity. So the summary of the session, what I have told you, first raw material, it has to be defatted, then extract, then after extraction, then it has to go for centrifugation. That is to remove the supernatant from the solid particles. And then that is called ultrafiltration. Then subject to the new generation chromatography to select that particular spike proteins. Then the subject to the STS paging, then you can see the bands, the allergen bands which is found, and you can ascertain that these are the present particular proteins. Once it is found, then you can sterilize, passing through the 0.22 micron filter, then lyophilize it. Lyophilization is a process where the liquid can be converted into a separating the water, which is becoming a ice, and ice is sucked out from the vacuum, and the remaining content will become dry powder. So this lyophilization will not harm or destroy the protein content in the extract. And after this lyophilization, you can ascertain the protein concentration, how much it is present. So protein quantification and standardization by method called Lowry or a Barford assay for a total protein. Allergen quantification done by ELISA, STS page, or a Western blot. And if you have a Western, you can compare this particular process with the reference samples. Usually the reference samples are given by the international societies. For example, US FDA. US FDA supply the reference samples to the manufacturers. And similarly, European Medical Agency also collect the samples and direct to the manufacturers so that they can collect the samples and compare it. And activity assay like a skin prick test, standardization in volunteers early phase, it has to be done so that you must have the volunteers subjects to do the SPT. Earlier we used to do it. Now it is not recommended because the ethics committee is not accepting this procedure to be formulated. Storage, it is in the form of aliquot and store at -20 to -80 degrees centigrade. Avoid repeated freeze thaw cycles. The reason is the moment you do repeated cycles by putting a water and again doing, the degradation happens. So you should be avoiding the repeated cycles. Label with the source, batch number, date of preparation, protein content, preservatives used. And you have to document it, maintaining a standard operating procedures, and a record raw material source, batch, size, yield, protein quantification, endotoxin checks, internal validation with a skin test respond if used for diagnosis. Now coming on to the allergen standardization. Allergen standardization is made biologically. The potency of the vaccine is compared to the cutaneous response obtained in the reference population. Immunologically, the potency of the vaccine is based on SDS page, Western blot, ELISA inhibition, that is RAST inhibition, experiment using a standard protocol of sera. Why we required a standardization with all these sophisticated equipments used? You see, the allergen extract used for diagnostic or immunotherapy satisfy requirement for potency, stability, absence of non-allergenic components, and a batch-to-batch variation. Usually, variations that occur between the preparation from different manufacturers and between different batches from the same manufacturer will affect the skin test, radioallergosorbent test, that is RAST, nasal provocation test, and hyposensitization therapy. So we have a standard units which we call in this extract. One is weight by volume. Is used for a crude extract is widely used 1 gram of pollen in 10 ml extract, which is called 1 in 10. If it's a 1 gram pollen used in 20 ml extract, it is called 1 in 20. The The known unit and a protein nitrogen unit were used for allergen products. That is 1 gram pollen in 10 ml extract buffer containing 100,000 known units per ml. PNU correspond to the 0.01 microgram phosphatotungstic acid precipitable nitrogen, which is approximately 0.06 microgram of protein. Another technology, another word we use, histamine equivalent in prick testing, that is HEP, which is also procedure which is used. 10 HEP is equivalent to the allergen concentration which elicit the same wheel size on SPT as 10 milligram per ml of histamine dihydrochloride. Biologic unit BU represents 1 in 1000 of HEP, since 10,000 biological unit per ml is equivalent to 10 HEP. Biological standardization based on quantitative skin testing, commonly US FDA advised the ID50EAL method, that is intradermal dilution for 50 mm sum of erythema diameter determine the allergy unit. So there are different standardization units are being defined of their own. Every company has got their own units. One is PNU is a worldwide is used. Allergy unit, only US FDA recommends. Bioequivalent allergy unit, PAU. Biological units in Europe. International units, WHO. Index of reactivity in the Europe. Specific treatment unit, STU. And activity units by RAST, that is AUR in Europe. Therapeutic unit in Germany. SQ standardized quality units by Alcabello. So the major and minor allergens are very important, clinically important and clinically relevant allergens, which you all know, and how these different products of different batches having a different, a strong major allergen and a moderate and a weak allergens in every extract batch will be having. So average, it should be more than 50 to 60% of the major allergen should be there. And it can be identified by complexity by CA cross immunoelectrophoresis. And what are the common methods which are used for standardizing allergens is skin test titration, preferably with histamine reference, immunodiffusion, histamine release assay, RAST inhibition, isoelectrical focusing, cross immune electrophoresis, lectin binding, and passive cutaneous anaphylaxis. Combination of SPT, histamine release, RAST inhibition, and CAE has proved to be the most satisfactory approach. Safety and compliance. Avoid microbial contamination. Try to use the personal protective equipment PPE. Comply with the local biosafety and biomedical waste guidelines. Future optimization ideas. Lyophilization for long-term stability. Non-filtration to remove endotoxins. Use of recombinant allergens or purified fraction for precise component resolved diagnosis and immunotherapy. So this is one of the STS page, how the experiment can be set and which can be used in most of the labs, and how these gels are generated within particular bands. And you can see the present of that particular protein. So similarly, the time is very short, I'll be covering. So just give you a brief about the key parameters to standardize. That is, total protein content is very, very important, which is commonly done by Bartford or Lowry assay. Biological potency, that is allergenic activity by skin prick test or inhibition ELISA. Major allergen content, that is ELISA, STS page, immunoblotting. Endotoxin load, safety of therapeutic use, that is LAL test. And stability, potency over time, that is recheck protein content activity at intervals periodically, at least minimum 3 to 6 months. So the slit extract optimization, rapidly evolving area, especially with the increasing preference for patient-friendly, non-invasive allergy treatments, optimizing for stability, delivery, and nuclear absorption can directly impact both efficacy and compliance. And stability of the slit extract, preservatives, which is very important, 50% glycerol is a very good stabilizer and antimicrobial. pH range optimal pH is 6.5 to 7.5, closer to the physiological solutions, and the temperature stored at 2 to 8 degrees centigrade. Light production use amber vials or UV block containers. Shelf life usually having 6 to 12 months. Test periodically with a protein assay. Usually 6 to 12 months is the common word we use. And if it is properly used, it can be used for 18 months. Then you have to use the proper dispensing, dropper bottles, 0.05 to 0.1 ml per drop. And you have to label as per the guidelines. And regulatory considerations in India by CDSCO and a in-house compounding of slate is permitted under physician-supervised settings. Maintain a batch records, key quality control, test for each batch, documentation of SOPs. Now, coming on to the another few minutes, chemical and physical modification of allergens. The aim is to improve the safety and clinical efficacy of the allergen-specific immunotherapy. The strategies: depot, effect of enhanced immunogenicity, physical adsorption to particulate carriers, improve antigen stability, adjuvants to enhance efficacy, physical adsorption to adjuvants or co-adsorption of adjuvants, increased dosage, reduced risk of IgE-dependent site reactions, chemical or physical modifications of allergens. Again, we can use the adsorption of alum, most widely used adjuvant in human vaccinations. And its mechanism is a steady supply of the dissolved antigen, presentation of a high local antigen concentration to recognition molecules, recruitment and differentiation of APC, optimum size of endocytosis by APC, and a powerful pro-oxidant potentiates ATP, favors activation of the NALP3 inflammasome and release of a pro-inflammatory cytokines IL-1B beta and IL-18. Another one is L-tyrosine, which is a depot adjuvant fully metabolized. And another is MPL, monophosphoryl lipid, and which is detoxified derivative of lipopolysaccharide of Salmonella Minnesota, TLR4 agonist, promote Th1 type immune response, induce IL-10 production from oral Langerhans cells. Heat denaturation, reduce Ig reactivity and enhanced immunogenicity favor Th1 response. So allergoids and hypoallergenic variants, what are they? You see, the allergen having a different modes of loops, and which is exactly binds on the Ig receptors. And this Ig binding on this particular allergen, to modify that, we can treat chemically so that the binding surfaces become flat or may not be available to the Ig molecules. So it becomes more with the immunogenic, but allergenicity will come down. And chemical modification, which is used, formaldehyde, glutaraldehyde, potassium cyanide. Some are restricted formaldehyde and glutaraldehyde because of the cancer-inducing factor. Potassium cyanide is also not commonly used. So hypoallergenic preparations have a substantially reduced capacity to induce Ig-mediated activation of mast cell and basophils. And preparations are not presented to APC by Ig-mediated mechanisms and therefore will not favor an allergic phenotype. Hypoallergenic preparations are T-cell activation and have the ability to induce a strong IgG4 response that are favored by IL-10, consistent with the regulatory T-cell response. So hypoallergenic allergy vaccines is physiochemical characterization, immunological characterization. Commonly, we call it as allergenicity, that is Ig reactivity. Antigenicity, that is binding to products of an immune reaction, maybe commonly antibodies, cell-bound receptors. And immunogenicity, ability to induce an adaptive immune response. Now, coming on to the recombinant methodology to prospect of recombinant allergens in specific immunotherapy. Recombinant is a process that combines DNA molecules from different sources to create a new genetic combination not found in the nature. And it is a technology is a joining together of DNA molecules from two different species. This technique to isolate, manipulate, and introduce specific DNA sequence into a host organisms, resulting in a recombinant DNA molecule. This technology is used to produce new organisms with the desired traits with application in medicine. This is how the DNA, which can be transcription or translation, can be done and which can be multiplied. I'm not going in detail about the technology. And you can see that electrophoresis silver stained having a grass pollen. They found out 1,288 protein spots. So much of rich molecules are present in the pollens. And patient-tailored or personalized immunotherapy also can be done. This is a PHLP1 of different fractions can be done with this recombinant intelligence. And according to the need of the patient, we can combine what particular fraction they wanted and they can use. So this is how the industrial development of recombinant is done. And what are the physiochemical characterization, structural characterization and conformation, like amino acid composition, amino acid sequence, peptide mapping, conformation of correct disulfide bridging, physiochemical properties like molecular weight, size isoform pattern, extinction coefficient, electrophoretic pattern, chromographic pattern, spectroscopic profile. Process-related impurities and contaminants in host cell proteins and DNA, cell culture dairy impurities. Impurities stemming from purification procedure, product-related impurities including degradation products, truncated forms, other modified forms, example, demediated or oxidized aggregates. What is the advantages of recombinant proteins? That is, molecules with defined amino acid sequence, preparations of consistent pharmaceutical quality, all batches of one allergen derived from same master cell bank, avoidance of possible contamination and the risk of infectious agents, dosage in the mass units in respect of all components, absolute standardization, inclusion of only the relevant proteins, optimization of the dosage of all components of a preparation, possibility to tailor preparations to a patient's sensitization profile, precise monitoring and investigation of mechanisms of action, option to create genetically engineered variations, example with reduced IgE reactivity. What are the disadvantages? Each allergen has to be developed using a specific approach and is a very long process. For those allergens occurring in many isoforms, it is necessary to identify the most relevant. It may be necessary to include more than one isoallergen in cases of limited identity. High development cost in relation to a limited market potential. Commercial considerations are likely to limit the number of recombinant products coming onto the market. So this is the victory what we are getting after procedures, and we are more success with a slate or a scale with a symptom score and medication score. Thank you very much.
Thank you, sir, for your very insightful talk and sharing your expertise with us and sharing your knowledge. We are deeply privileged for this. So just one or two questions, sir. So during pollen collection, does it matter if we collect it from an urban area versus a rural area, or on low AQI days?
You see, the collection of raw material is very, very crucial. First, you have to identify the plants. And once you identify, then the pollens, the flower should be identified. If it is a totally bloom, that means the pollen is already widely open, then the contamination should be there. So you should be halfway open.
Okay.
And also the time of collection of pollens is very important. That should be done in the morning before the insects start flying on the plants. Otherwise, it will contaminate the pollens.
Okay, so thank you, sir. Sir, and from your talk, we understood that especially standardization, like you said, it is such a long procedure and a difficult one, definitely. So, can you please tell us why the Indian manufacturers are finding it difficult to get standardized allergens? And as a national body, allergy body, how can we help to achieve this? I mean, in our country by to get standardized allergens?
See, the standard procedure is very, very crucial and very important, but it's not possible to do it. And most of the, even the international agencies which they are manufacturing allergens and what is available in India, at least we are making the STS paging is a standard protocol which has to be done. That is what everybody is doing now. And in internationally, we have only about 10 to 14 allergens which is standardized, and rest of the things is not standardized. So it is a very crucial process and very elaborate procedures are there.
Okay, so probably because we are not able to do these this
It can be
SDS
done.
page.
It is not possible. It is not a task which is impossible to do it. It can be done, but it is a very tedious procedure which takes a long time.
Okay. Thank you so much, sir. If any other questions, if we come across, we'll definitely get back to you, sir. And thank you so much for this excellent session, sir. We are deeply thankful to you for this and for your time and effort, sir. Thank you so much.
Thank you, madam. Thank you.
Yes, yes. So we can now we can move on to the next talk for the webinar series, that is balancing safety and efficacy of managing reactions in allergen immunotherapy. This talk will be delivered by Dr. Deepti Pujari. She is a senior pediatrician and allergy specialist working at Dinanath Mangeshkar Hospital, Pune, and also her own clinic, which is the Pujari's Pediatric and Allergy Center. She is a European board certified allergist, and she's a great academician and a wonderful speaker. And she's a faculty for various modules which are run by the IAP, and also she's the executive board member of our chapter this year. I welcome you, Dipti ma'am, to this session, and we are looking forward to hearing from you.
Thank you, Dr. Sanchana, for that wonderful description. I doubt I deserve all that. Okay, so let me share my screen. Can you see the full screen, please?
Yes, ma'am. We can see that.
Okay.
Yes.
So it's a real task for me to speak after such a wonderful session by Dr. Nagendra sir. I hope I do justice to it. So thank you, IAP Allergy Chapter, for giving me this opportunity. So I have been told to speak everything about safety and efficacy and how to manage all the reactions that we are facing during the allergen immunotherapy. So what I thought is I would quickly go through what all side effects we face during what time of the allergen immunotherapy we face during slit and skit, and possibly can we avoid them and how to manage them. So we all know that safety of allergen immunotherapy is a concern. We are in 2025, but still we keep talking about safety of this procedure. To be very honest, allergen immunotherapy is really safe and well tolerated. Systemic reactions do occur, but they are extremely, extremely rare. And as you can see from these various studies that I have put, especially the American Academy, they did a big survey and they found that between 1945 to 2001, that was ages back, there was just 1 in 2.5 million injections, fatal reactions, and now it has dropped to 1 in 9 million injections between 2008 to 2016. So, fatal reactions are extremely, extremely rare, and that's what exactly I want to say, that allergen immunotherapy is quite safe. But still, in next 25 minutes, we'll try and find out what are all the side effects and can we prevent them. So this is all I have put this slide to show from where I have taken all the data. This was a big study, almost international global study, I would say, from European and American centers. So it was data complete from randomized, multi-center, double-blind, placebo-controlled phase 2 and phase 3 trials for Timothy grass, ragweed, and 12-HQ house dust mite slit tablets. From here, I've taken my data, and now I'm going to speak about side effects of sublingual immunotherapy. So actually, let's see what are side effects. A serious adverse event was any adverse event that resulted in death or was life-threatening, that required prolonged hospitalization, that resulted in persistent or significant disability or incapacity, that was congenital anomaly or birth defect in offspring of a study subject, or that consisted of any other medically important event as determined by the investigator. So if any of these come across, we should call it a severe or a serious adverse event. Okay. So commonly reported adverse events with slit tablets, almost more than 80%, okay, more than 80% treatment related adverse events were oral reactions of sublingual immunotherapy tablets. So like throat irritation, oral pruritus, ear pruritus, mouth edema, uvula swelling, tongue swelling, lip swelling. So mostly all were local. And what were these? Let's quickly go through, because that's what we are going to deal day in and day out. So we should be well aware of these adverse events. So throat irritation was very common. Almost 40% of the patients reported with slit tablets. But almost 12% of them with placebo tablets also reported this. So how strongly we should take it? It should always be taken with a pinch of salt, but of course we should pay attention that it is one of the very common adverse effects. Sensation of scratchy feeling at the back of the throat, that's what most of the patients said, and generally occurred on day 1. Okay, recurred for almost 4 to 12 days. So occurred on day 1, but it would continue for a couple of weeks. Irritation lasted from 10 to 55 minutes after the tablet intake. So grass pollen, weed pollen, or your house dust mite tablets. So the importance of keeping the patient at least 30 minutes to an hour after taking the first tablet. Okay, then comes the oral pruritus. Again, almost 10, anywhere from 10 to 40% of the patients reported about oral pruritus. Again, there were some placebo reports also. Sensation of itching in the mouth, again, occurred first on day 1. This also lasted for almost 12 days and would last only up to 30 minutes. That was just some itching in the oral cavity. Ear pruritus was less common, almost up 7 to 30% of the patients. Sensation of itching inside the ear and a need to scratch the tongue near the orifice around the eustachian tube. That was complained by almost 30% of the patients. The best part again occurred on day 1, lasted for not more than 10 days and would last only for 20 to 30 minutes after taking the slit tablets. So here, everywhere we are seeing that most of these local adverse effects lasted not more than 30 to 40 minutes. So the importance of seeing the patient on day 1 in your clinic, keeping them for at least 30 minutes to 1 hour. Then comes the mouth edema. Reported in almost 10% of the patients, sensation of swelling at the site of tablet placement. So in my practical experience, I'm seeing this in almost all the patients. It is written here 10 to almost 11%. But again, it's very common and very, very typically this occurs after a week of tablet intake. Very correctly done by this test also, day 7 to day 11. Never seen in the first week. After first week, patients come back saying that there is swelling underneath the tongue. Recurred for range of 6 to 27 days. Again, lasted for not more than 30 minutes. So, most common treatment-related adverse events are oral reactions, experienced the first day of treatment, recur for less than 2 weeks, generally resolve within 30 to 60 minutes. Half of the patient who discontinued due to adverse effect did so within 14 days of the first slit tablet dose. So again, this is the importance of your counseling, your how approachable you are to your patient. You need to talk to them. You have to reinforce that these are just temporary, they would settle down, because half of the patients who discontinued did during the first 2 weeks, that is when the local oral adverse effects were maximum. The onset of mouth edema tends to be delayed, as I said, compared to the other adverse effect. It mostly occurs after 1 week of taking the slit tablets. Okay, now the golden question, risk of worsening asthma. Now, mind you all, friends, this randomized control trial, multi-center trial, double-blind placebo control trial, all these trials, they made sure that the patients who were recruited or whoever was recruited, the FEV1 was at least 70% of the predicted for enrollment. This is the key statement. Whoever's FEV1 was less than 70%, meaning the asthma was not well controlled, they were not included in this trial. So, with this underlying feature, 1/4 to half of the allergic rhinitis patient had a history of asthma. There was no difference in the proportion of patients with treatment-related adverse effects among patients with asthma compared to patients without asthma, because, as we see, their asthma was well controlled when they started this sublingual immunotherapy. There was no difference in the incidence of asthma-related adverse events in the slit tablet versus placebo. So it was seen in a well-controlled patients, it was quite safe. The most frequently reported asthma-related adverse events were asthma, cough, and dyspnea, and the majority of the events were reported by the investigator to be mild or moderate in intensity. So they were easily controlled, easily treatable, and could be easily counseled. None were worse. So, what is the one conclusion? Slit tablets are contraindicated in patients with severe, unstable, or uncontrolled asthma and should not be initiated in asthmatic patients with ongoing respiratory tract infection. So, very important, you control the asthma and then you start your slit immunotherapy, so the chances of adverse reactions is to its minimum. Now, what about the potential for severe systemic side effects? So, the systemic side effects that were seen were syncope, hypotension, tachycardia, rhinorrhea, sneezing, dyspnea, cough. These were not very severe, but of course they were considered. Wheezing, bronchospasm, chest discomfort. Then on the skin, there was some rash, pruritus, flushing, urticaria. Abdominal pain and diarrhea were considered local, or because they were considered as a continuation of the slip tablet, the oral cavity continuing down, but some considered it as a systemic side effect as well. And then, of course, we know anaphylaxis, which is systemic. What about eosinophilic esophagitis? So, several studies, I went through a lot of papers and I've taken two most important papers. Direct association between slit tablets and eosinophilic esophagitis cannot be confirmed, was clearly stated in this Journal of Allergy and Clinical Immunology in February 24. It was a big study done. Allergen immunotherapy could place individuals at risk for the development of EOE, the true incidence of which may vary depending upon the antigen exposure and methods used to define the condition. So as I was going through the papers, one thing was sure, that association between slit tablets and eosinophilic esophagitis is not one-to-one. It's not directly, they are not at risk. But most of the papers said that if there were some abdominal issues, there was some history of esophagitis in the past, they all refrained from taking slit tablets. But otherwise, direct association between slit tablets and EOE was not confirmed in any of the studies. Coming to the systemic reactions, because that's what we all are worried about. Local reactions, easy to manage. Across the clinical developmental programs of Timothy grass, ragweed, and house dust mite slit tablets, no life-threatening or serious systemic allergic reaction were seen. 11 systemic allergic reactions were reported with slit tablet. No life-threatening, but yes, systemic reactions were reported. 10 were mild to moderate. Only one severe. So no life-threatening, only one severe slit tablet-related systemic allergic reaction was reported on day 6. That was symptoms of throat swelling. I told you the swelling appears mostly after 1 week. So there was throat swelling, dyspnea, nausea, lightheadedness, oral reaction, which occurred on day 6 of treatment with ragweed tablet. The majority, 6 out of 11, of the reported systemic allergic reactions had occurred on day 1 of treatment. Again, the importance of giving the first slit tablet in your clinic and asking the patient to sit at least for an hour so that you can see the side effects and you can counsel the patient likewise. Now again, the million-dollar question. Should epinephrine be prescribed to everyone whom we are giving slit allergen immunotherapy? Out of these 8,152 subjects receiving slit tablets, there were 16 epinephrine administrations for treatment-related adverse events. Only 6 of the administrations were for systemic allergic reactions. Not severe, but at least there were systemic allergic reactions. 10 of the administrations were for local reactions, and none of these adverse events were serious. So, a big question, what is the use of epinephrine then? Of the 16 administrations, 7 were administered by healthcare professionals during the day 1 of observation period. And this study already said that none were serious side effects. It may be, so what did this conclude? It may be difficult for healthcare providers to decide if epinephrine should be administered. So the healthcare workers themselves were not very sure whether epinephrine was needed, but on day 1, most of them didn't want to take the risk, so epinephrine was given. So then a big question, what about the lay people? Would they be intelligent enough to use epinephrine wisely? So what did this study say? It is important that the prescribing physician educate the patient about the signs and symptoms of anaphylaxis to ensure appropriate use of the autoinjector and avoid unnecessary epinephrine exposure. None of the studies said that prescribing epinephrine is compulsory during the slit tablets. But yes, you can give them and you should educate the patient properly. Coming to, because my topic also contained management, we'll have a quick word on management of anaphylaxis. Adrenaline, adrenaline, adrenaline. We all know by now, we have had a good series on anaphylaxis, so I'm keeping it extremely short. Intramuscular 0.01 milligram per kg, 1:1000, that is your undiluted adrenaline. Should be given intramuscular on the lateral aspect of the thigh. Maximum dose has to be 0.5 milligram, or depending upon the weight, up to 10 kgs, you can give 0.1, 20 kgs, 0.2, 0.3, so on, but 0.5 milligram is the maximum dose. If the patient has not recovered completely, you can repeat the dose after 10 minutes, and then the patient should definitely go and attend the nearest hospital or should call the ambulance. When should slit tablets be discontinued? Escalating local side reactions. So not necessarily generalized reactions, but escalating local side reactions or any swelling, throat tightness that causes difficulty in speaking, breathing, or swallowing. This is one condition where slit tablets should be discontinued. I'm repeating, I have not put the citations everywhere because I have taken all these from that major worldwide study which I had put on my first slide. Severe systemic allergic reaction or has severe or persistent symptoms of esophagitis, such as chest pain and difficulty in swallowing. Any history of esophagitis is a contraindication in United States. So, severe systemic allergic reactions or esophagitis. Patients experiencing inflammation or wounds in the mouth, including tooth extraction, should temporarily stop treatment until the wound is healed. Patients with asthma have difficulty in breathing or the asthma becomes difficult to control. Even then, the slit tablet therapy should be discontinued. So this was the conclusion from all the studies worldwide. Okay. Now, with that brief discussion on sublingual immunotherapy, let's come to subcutaneous immunotherapy, its adverse reactions. So again, we'll quickly go through it. Adverse allergic reactions in SCIT, that is your subcutaneous immunotherapy, are classified as local and systemic. And most of the time, it is the local reactions which we are worried, because amongst the local reaction, there is something called as large local reaction, which is defined as pruritus or erythema more than 2.5 centimeters at the site of injection. Okay, as many as almost reaching up to 86% of the patients receiving SCIT experience local reactions. So 26 to 86% of the patients definitely they experience some form of local reaction. Again, the importance of counseling the patient before starting your SCIT, otherwise there could be a lot of dropouts. And remember about these large local reactions, they could be very much disabling and irritating and concerning to the patient and to the parents. So between 1990 and 2000, the study showed the National Survey of Allergists in North America, one fatal reaction occurred after every 2.5 million injection visits. That is averaging to 3.4 fatal reactions per year, and that is considered extremely low. So these are some of the side effects. These are real patients. We commonly see these. This is a large local reaction at the site of injection. Okay. So risk factor, what are the risk factors for fatal reactions during SCIT? As I had said in SLIT, here also it stands to uncontrolled asthma at the time of administration of injection. It is considered one of the biggest causes, the most important one for fatal reactions. The asthma has to be under control when we start our SCIT. Dosing error. This was also commonly seen that updosing, especially while updosing, incorrect dose were given, higher doses were given by the technician or the nurses who were giving. So I feel in my practice, I myself give, I don't allow anyone else to give it, because dosing errors should 100% be avoided. Delay or inadequate administration of epinephrine during anaphylaxis, again the role of epinephrine or keeping it at least ready. The crash cart should be ready in our clinic while we are giving SCIT. A prior history of injection related systemic reaction. If someone has already had a bad systemic reaction, there are chances of getting a repeat bad severe anaphylaxis increases. Now, a very important study here. What did it say? Patients with a history of systemic reactions had a rate of systemic reactions that was fourfold greater than those without the history of systemic reactions. One third of these patients' reactions had been preceded by large local reactions. So, systemic reaction and large local reaction, if you had once, there are chances that they can be repeated again. Okay. But then, in spite of this, what was the recommendation? Okay, it was published in Allergy, Asthma, Immunology journal. The recommendation says there is generally no need for dose adjustment of SCIT after a large local reaction, as such adjustments have not demonstrated significant reduction in the risk of subsequent systemic reactions. Meaning what? Whether you decrease the dose of your SCIT after LLR or you don't, the chances are high only. There are high chances that you will get another LLR. Nevertheless, it is reasonable to repeat the same dose. Don't increase the dose for your next shot, or adjust the dose for individual patients considered to be at greater risk for a systemic reaction. Especially those who have had a systemic reaction in the past, we know there is fourfold chances that the patient might have systemic reaction again. We don't want that. So what did this study said? You have to take the call. Either repeat the same dose if you are, this is all we are talking about the build-up phase, okay? Conventional, cluster, whatever. So either you repeat the same dose, don't increase the dose in the next shot, or in fact, you can adjust the dose, even decrease the dose in the next shot of subcutaneous immunotherapy. That has clearly been mentioned. So what about the management of local reactions? Local reactions have to be managed with your antihistamines. You can pre-treat the patient with antihistamines. Cold compresses are the best. I have been trained under late Nagaraju sir, and he always said you have to put cold compresses. They are the best. They decrease the local reaction, the wheal flare, the itching, everything decreases if you cold compress and press the site of injection. Splitting the dosing. This is especially important. It is not for systemic reaction, but if a patient is suffering from repeated large local reactions, every shot you give and there is large local reaction, splitting the dose in both the limbs, half on one side and half, will decrease the local reaction on both the sides. Schedule adjustments. Again, if there is systemic reaction in the past or there is large local reaction, you don't want to do your rush immunotherapy or cluster immunotherapy. You would rather go on a conventional therapy. If on conventional therapy also you are facing these systemic reactions, large local reactions, then you would repeat the previous dose or even decrease, go one dose prior if the patient is reacting a lot, and definitely you would then pre-treat the patient with antihistamine and then give your doses. And last but not the least, educate the patient, talk to the patient, counseling the patient, telling them everything about allergen immunotherapy, telling them beforehand they are expecting local reactions, nothing to be afraid of, they can be treated locally. All these need to be, patients and the parents need to be counseled properly so that there is less dropout during your skit, conventional or cluster build-up therapy. Okay. What is the fact then? The rate of skit-associated systemic reactions of varying severity is relatively low at 0.1 to 0.2 with conventional build-up protocols. The rate of systemic reaction is increased with accelerated cluster build-up regimens. So that's exactly what I was saying. If there are a lot of side effects, it's best to go via your conventional build-up protocols. Again, a very important paper published by World Allergy Organization on subcutaneous immunotherapy. It has been said that every consultant or an allergist who is giving subcutaneous immunotherapy, they should be well versed with the grading of side effects, because they should be able to treat accordingly. So grade 1 is the least and grade 5 is worst, that is your fatal reaction. So in grade 1s, your cutaneous or upper respiratory or conjunctival or abdominal symptoms are mild. You get some swelling, itching, irritation, cough. These are some of the reactions, urticaria, flushing. But in grade 2, these reactions increase in severity. So from upper respiratory, just rhinitis, sneezing, watering from eyes, nose, throat irritation, it goes to lower respiratory. You might face asthma, cough, wheezing, shortness of breath, FEV1 dropping quite a lot. So here you need to quickly pick up grade 2 reactions, or gastroenteritis. You might get severe abdominal cramps, vomiting, diarrhea. Grade 3, asthma can worsen and this patient may not respond to your inhaled bronchodilators. That is your grade 3. There could be laryngeal, uvular or tongue edema with or without stridor. So this is considered grade 3. Laryngeal and uvular edema could be life-threatening. So it is considered grade 3. Grade 4, lower or upper respiratory failure, lower upper respiratory symptoms with respiratory failure with or without loss of consciousness, and hypotension with or without loss of consciousness. That is your grade 4. And grade 5, definitely it's a fatal reaction. So everyone who's doing skit should be well versed with this grading system. So again, North American surveillance project was initiated to annually survey skit reactions among certified allergists between 2008 and 13. 2 direct reports of fatal reactions were confirmed in patients treated by allergists, and 2 indirectly reported events occurred under the care of non-allergists. This study provides evidence of improved safety of skit. One life-threatening grade 4 systemic reaction was reported in 1 lakh injection visits. So the rate of side effect decreased dramatically between 2008 and 2013, and it was considered that the reason could be controlled asthmatics were kept in this study. So anywhere where the asthma was not under control, they were excluded from this study. So that was one single factor. And mostly they didn't start the study at the peak of pollen allergy. Apparent decrease in the number of injection-related failure, careful pre-injection screening, and withholding of injections from patients with uncontrolled asthma. One more observation, clinical practices that never administered injections to uncontrolled asthmatics reported significantly fewer systemic reactions, and practices that reduced allergen skid doses in highly sensitized patients during peak pollen season. This was again very, very important because when there was peak allergen pollen season, they decreased the skid doses that dramatically reduced the systemic side effects. So 14% of the reported systemic reactions began 30 minutes after the injection administration. Again, as in slit, very, very important that patient at least sits for, if not 1 hour, 30 minutes to 1 hour is what is said. The patient should stay in your clinic so that you can keep under observation. Most of the late onset systemic reactions were mild or moderate. So if fatal, it was within 1 hour. The late reactions were mostly mild or moderate. Patients rarely self-administered epinephrine during these events. So best they stay in your clinic. Should epinephrine be prescribed in SCIT? Again, current guidelines do not recommend routine prescription of self-injected epinephrine and state that the decision to prescribe epinephrine to patients receiving SCIT should be at the discretion of the physician. So you can give, but if you don't give, you won't be taken to the court of law. It's best that you counsel the patient and give it and tell them the correct indications to use epinephrine. A quick word on venom immunotherapy. SCIT with Hymenoptera venom is generally well tolerated by most of the patients with stinging insect anaphylaxis. Systemic mastocytosis was one of the major risk factor for severe systemic reactions to VIT injections. It was not VIT itself, but underlying systemic mastocytosis. Compared with wasp VIT, honeybee VIT injections present a relatively higher risk to systemic reactions. So now we don't have basophil activation, but they said basophil activation assay was the predictor of severe systemic reactions to VIT. Unfortunately, we don't have this tool. Short interval between the sting and the onset of symptom. If it was less than 5 minutes, it was associated with severe systemic reactions. So these were some of the very important observations. Now, the authors recommend routine measurement of basophil activation prior to starting honeybee VIT, but unfortunately, we don't have this. But definitely, if there is a short interval between sting and onset of symptom, we have to keep ourselves on the toes. This patient might have severe VIT reactions. So again, a contraindication to allergen immunotherapy. This is a big position paper by Iaki published in 2015 and then updated. What are the absolute contraindications for allergen immunotherapy? Uncontrolled asthma, active malignant neoplasias, AIDS, age less than 2 years, and pregnancy for initiation of AIT. If it's already there, you can continue, but we shouldn't start allergen immunotherapy during pregnancy. So these were the absolute contraindications, and relative contraindications being partially controlled asthma, use of beta blocker and ACE inhibitors, cardiovascular diseases, HIV infections, immunodeficiencies, HIV infection, okay, and there it was AIDS, full-blown infection. Immunodeficiencies, psychiatric and mental disorders, because otherwise it becomes very difficult to counsel these patients, and use of immunosuppressive drugs. These were relative contraindications. So to conclude, allergen immunotherapy associated with adverse effects occur in minority of the patients. Severe reactions are rare. The presence of severe asthma and use of SCIT are risk factors. Decision to prescribe AIT should be based on an evaluation of the condition of the individual patient. Physicians should always consider the balance of risk versus benefit when prescribing AIT. Thank you.
Thank you, ma'am, for that wonderful talk and giving us very crystal clear messages. And the key messages were, like you told, were counseling of the patient, for adverse reactions, which is a very important thing before we start the immunotherapy, and also observation in the clinic, as you told. And it cleared a lot of doubts for us, actually. And we would go to the questions in the right now itself. And is it okay to pre-treat all patients of SCIT with antihistamines to prevent local reactions? Will it improve the compliance, ma'am?
Yes, so even the studies say, and I've observed in last so many years, pre-treatment, especially for the first 1 or 2 weeks, when the local reactions are maximum with the slit tablets or slit drops, tremendously improves the compliance. Patients feel more comfortable, they get confident, yes, this therapy is safe, there is nothing to fear about it. And after a couple of weeks, you can stop and continue it and take your sublingual immunotherapy very nicely. So, yes, it is very useful pre-treatment of slit. In my practice, I am using only in very selected patients. If I feel I've counseled the patient very nicely, parents are happy, child is happy. Not every patient I treat with antihistamine. But after a week, if they're coming with that sublingual edema below the tongue, and if that is severe, because that is one thing I'm facing with slit tablets, then I definitely give for a week or so, I give antihistamines. Not all patients before starting slit, I'm giving antihistamines, none. And it is not even recommended.
Okay. But at that time, in fact, if we have not prescribed epinephrine, are we justified in giving an epinephrine, especially when there is local edema and all?
So
Like,
we
should
don't
we
give
worry about?
epinephrine. We don't give epinephrine. It's antihistamines.
Yeah.
Simple antihistamines, oral antihistamines, your second generation antihistamines for a couple of weeks, and the edema disappears and it never comes back, mostly. So
Okay.
don't prescribe epinephrine for all the patients, just antihistamines for a couple of weeks.
Yeah. And in case if there is a moderate to severe respiratory tract infection, is it necessary to withhold the immunotherapy
Yes.
or?
Yes, even the guidelines have said if there is high grade fever and lower respiratory tract infections, you have to withhold the allergen immunotherapy till the infection is cleared. All lower respiratory tract with high fever, you have to stop temporarily.
Okay. Viral colds, I think, should be okay
Yes,
to continue. If
yes,
like minor colds and all should be fine.
yes, yes. Minor cold coughs, you can continue.
Okay. And if in case there is a oral ulcer, how should we reduce, whether we should reduce the slit tablet dose, and how do we reduce that, or shall we stop first?
So we cannot reduce the slit tablet
Yeah.
dose.
Yeah.
Tablet is one, you cannot break it.
Yeah.
You're not
Or
allowed
the
to do that.
drops. Yeah.
Okay, so drops also, decreasing the drops wouldn't heal the ulcers. So best is you can temporarily for at least 2, 3, 4 days stop immunotherapy. Make sure the ulcer is completely healed. Let it take 5 days also, because that is one contraindication for slit. Oral
Okay.
ulcers, tooth extraction, anything that is injuring your oral mucosa, slit shouldn't be continued, because there is breach in the oral mucosa. So we
Okay.
don't want that. So it has to be healed and then you can start your slit.
Okay. Thank you, ma'am, for those questions. If later, if we get some other questions, we'll definitely get back in the panel discussion. Thanks a
Thank
lot
you
for
for
this.
giving me the opportunity. Thank you.
It was a privilege for us, ma'am. Thank you. Now let us move on to the next talk and for today. And the topic would be guidelines in action, adapting global norms to Indian realities. And it's a very new novel topic. And to speak on this, we have Dr. Narmada Ashok, ma'am. She needs no introduction, but as a formality, she is a consultant pediatrician and allergy specialist at Nallam Medical Center, Vellore, and she is also faculty for the DA course, and she's been my teacher, and presently she is also the state secretary of Tamil Nadu branch, and she is also the executive board member of our chapter for 2025. Madam is a faculty and core team member for various modules by IAP. She's a great academician, wonderful speaker, and a very enthusiastic and wonderful person. I would like to welcome you, ma'am, for this talk, and it's a privilege to have you here.
Thank you, Sanchana. Today also I was telling in the DAA program, guys, better gear up. As soon as you complete your DAA, you will be one of the top people like Sanchana. So you better learn properly here.
That's so kind of you, ma'am.
Thank you. Thank you. And thank you, Dr. Neeraj. You always give me a very challenging topic. Of course, most of my topic was covered today, but still that's easy for me to start on. And they had laid the foundations for this. So having said that, 1 minute, I think I got the wrong slides. Yes. So
Yeah, it's seen, ma'am, only slideshow.
yeah, right. So the topic given to me is guidelines in action at adapting global norms to Indian scenario. Dr. Nagendra sir very beautifully laid the foundation of what is happening with regard to the preparation and this, while Dr. Deepti, my dear friend, covered all the factors of when to give and what happens and all the side effects. So the base has been laid. So now my question is, how am I going to convert that into the norms in Indian perspective? Because we have a great challenges ahead of us. So the outline will be what are the global standards with regard to the same, what are the advantages of the same in the countries that have the global standards. Now, what about the Indian perspective?
Ma'am,
Yeah.
sorry to interrupt. It's not in slideshow.
Oh, okay. I will share again. Is it in slideshow?
Yes, ma'am.
Yeah.
Perfect.
Yeah. So is it moving, right?
Yes.
Yeah. So I will be dealing with what are the feasibility of allergen administration in Indian standards, what is the feasibility in our actually small clinics also, where we have started giving immunotherapy, and our future goals and recommendations, which both of the speakers earlier had alluded upon. So we all know allergen immunotherapy, to give a new perspective to it, it is a precision medicine strategy. That is how it has moved on from what has been there. Because India, basically, we are all targeting at only the treatment of the symptoms. Now we are looking at a new factor in the treatment modality, which is a precision medicine, and giving a total direction towards changing the way the disease behaves in an individual. This is a disease modifying treatment available, and it's the only treatment which can be disease modifying. Of course, we are having biologicals, all that coming into the market, but immunotherapy is the only one that can modify disease, that can prevent the neosensitization. Having told that, the global recommendation as of now, GINA 2025 has clearly endorsed using the allergen immunotherapy for dust mite, for allergic rhinitis, and ragweed is in the pipeline. Moderate asthma requiring medication in step 4, which Dr. Deepti very clearly told that severe asthma, which is step 5, we cannot be controlled with immunotherapy. So she's very clearly told that. And of course, atopic dermatitis, the food allergy, the research is still going on, and we have clear recommendation for insect venom hypersensitivity in the global forum. Now, having said that, there is a dynamic thing of both the skit and the slit here. While US has been very comfortable with using the skit for a very long period, since they started using in the 1940s, till the Europe came up with a recommendation. They initially had a lot of restrictions to use slit because they were having so much studies with regard to the skit. And then we look at into sublingual immunotherapy, which Europe took it on immediately, because skit had a lot of complications with regard to the side effects and systemic anaphylaxis, as it was very beautifully discussed with Deepti Puja. So slit was one that was they took on very easily. And after their initial success, the US slowly started on, and now they have recommendation for the same. Both of them, of course, act on the dendritic cells, and there is a change in the Treg cells to from a Th2 immunity to a more favorable immunity in the sense of allergy, the Th1 and Th17. But having said that, the slit basically acts more on the dendritic cells and has got a thing to act with the cell-mediated immunity, whereas subcutaneous immunotherapy acts also on the B cells with having a suppression, induction of the IgG4 with suppression of IgE more prominent. So this has basically got to do with what is being dealt in our immune system, because we know the sublingual immunotherapy basically goes through the oral lymph nodes, which are very active, as well as the dendritic, as well as the oral mucosa and the dendritic cell, whereas the subcutaneous immunotherapy has got a more of a systemic manifestations here. So having said that, the subcutaneous immunotherapy has got a greater potential that also leads to more complication, but there has been a well-established protocol for the mite allergy, which has been existent for almost several years in the US. The grasses, animal dander, and cladosporium have also come into the market, and you can give the multiple aeroallergen immunotherapy for multiple allergens in a single shot. The efficacy is more, whereas the sublingual, we have seen that though it is on the highly dendritic cells, it is safe and it's better tolerogenic, but the studies are much more limited, and generally it is reported only from the gas pollen, and efficacy studies are still needed. So what happens in the US? What is that is where the first immunotherapy started. As I said, until 2007, as Nagendra sir said, it's very difficult for us to produce a standardized allergen. Until 2007, even in US, which has been practicing immunotherapy right from 1940, did not have a regulatory body for allergen preparation. It's only in the 2007 that allergen extract immunotherapy preparation guidelines really came up independently. First, we had the Joint Task Force of American Academy of Allergy, Asthma, and Immunology, and then the QuadAI, which is the American College of Allergy, Asthma, and Immunology, and the Joint Council of Allergy and Immunology all came up, and then subsequently it was embedded into the US pharmacopoeia. So this was a major change here with regard to standardization here. So what happened is, till then, now the US, it is basically, we have to understand the US standardization, where it is more physician dependent. They started the fellowship program right about 1970s, when our PK Vedantan sir when he used to tell, I never understood until I prepared this slide presentation. So there what happened is, they also regulated two FDA regulatory program came up, like Good Manufacturing Practice and Center for Biological Evaluation and Research, that is the CBER. So they actually wanted to standardize this extract. So what they did is, the allergen extract, they took it in the liquid form. They classified as whether it is a standardized or a non-standardized. In the non-standardized extracts, they started to tell them that it was a protein nitrogen unit or weight of the source material. And the standardized extract, they had, which was already touched upon by Dr. Nagendran sir. He said that about this ID50. So what is this ID50 is, they took the standards and they saw what amount of the reference preparation of the allergenic extract, that is the major protein, that can cause a biological equivalent allergy units of about with an intradermal testing of 50 millimeters. So they verified it about in most of their products. They found out what amount of major allergen is capable of giving this values, and then they selected an in vitro assay. So for this, the greater problem which we look at is, they need volunteers to do this. And we did a standardization testing in CMC, and you can see that to get a volunteer to take up this amount of intradermal testing is very, very difficult, and it will be completely, they have to be motivated to do this. But yes, they did this standardization for more than about 18 allergens there, and they initially took up the dust mite, and then they took up the pollens, which were very common there, which helped them to standardize these products. So once they did it, they kept it as a national reference standard, and you can see the year in which this intradermal dilution for 50 millimeters was ID50L was actually published. It's way back in 1982 in November. So you can understand when they actually started their process. After once they standardization, you can't be doing this for every, you can't ask the manufacturers to do it and show in the live subject. So they developed the in vitro assays where they used the quantitation of the protein content by hymenopterin, or they looked at for the venoms, they looked at the entire protein content. But when it came down to the allergen extract, they saw in ragweeds and cat pelt, they used specific allergen content, and which is their major allergen, which was already spoke upon. And sometimes in cases of grasses and mite, they also used whether the inhibition of the binding IgE from the pool sera to the reference allergen. So the reference allergen was done with the in vitro assay. So they had the quantitation done. So that standard allergen was originally prepared by testing on the 50 humans wherein they're getting the dilution. The subsequent assays, whenever the manufacturer submits, they have to be compared with the in vitro standard of the reference protein. So this is what their standard looked at. So they also used isoelectric focusing, protein separated based on the electrode point. This methodology gave them the method wherein they were exactly able to quantify how much of major allergen should be there in each of the preparation. So it's easy, they chose the product. They established what was the ideal in that is intradermal diameter of 50 millimeter for the reference product. Then they developed a surrogate in vitro testing for the lot release, and then the product manufacturer is going to compare this with the in vitro assay. See, as Sir answered to Sinchana, that this is very, very labor-intensive process, but it has been done by them, and they put up this transfer. But one of the things is there were only the few companies prepared this, but they prepared in lots. The main if you were initially, when Dr. Vedantan used to bring us the dust mite allergen, it used to be in 30 ml bottles, which was very much concentrated. Actually, when we used what we used in our study to compare the Indian standards and the American standard, we actually got the concentrated dust mite from the company from US, and then we gave it to the pharmacy in CMC, which actually diluted, and we had various dilution of the standardized allergen to be compared with the Indian allergens. And we actually compared 1 in 100 dilution, 1 in 10 dilution of the allergen standards with the Indian standards. So that was the kind of the concentration we got it. So here in US, the concentrated solution is there. And once their training was there, what happened is each of the physicians or allergy specialists prepared their allergen extract by an aseptic technique in a laminar floor hoods, as sampling and sterility testing. So they had to undergo all the people who were preparing had to have to really undergo a testing which has been told by their allergy, by their government agencies. They will have to pass the exams. And there were issues with aseptic technique. In some institutes, they actually used gloves for the preparation, and some they didn't use. Even the specification of the laminar flow hoods was given, and then they also had to label. Now, as well as the diluent used were more of the glycerol saline. Sir actually told about this glycerol saline. If you would have gone through the topic, he very clearly told me that glycerol gives a long shelf life. But if everybody can use it, or what will happen when the patient side of it, when they came to the diluted quantity, they had to use about saline with 0.03% of human serum albumin, which gave them more shelf life. And some people used a normal saline in the dilution. So when it was used with the diluents with a different standard, the shelf life has to be very specified. So you can see they actually had these small bottles where they prepared the 1:1 dilution. That is the maintenance solution used to be prepared first, from where the diluents for the 1:10, 1:100, 1:1000, 1:10,000 used to be there. Each of them has to be labeled. The allergenic extract came in the whole format from which they have to know how much amount is needed for this particular patient. And they use this printing label was so specific and in their offices to prepare this allergen. So US completely had a different methodology of preparation. And you can see that they were actually, it is a biological biological unit, because you are actually doing it in human and you could find out the biological potency for it. So they actually gave, for a standardized model, they gave the biological units. For those non-standardized, they used weight by volume. So if for the non-standardized extract in Poland, you can see it is either protein nitrogen unit or weight by volume unit. But however, if you can see for the most of the dust mites, the grass, they gave the standardization of how much to be used per ml. So the major allergen content was exactly quantified in the US licensed extract. Having said that, what happens here is the advantage you should see is I can use any of the company's products. The company products are going to have the same standard major allergen content. And then the dilution is actually done in the physician's office, wherein he has the liberty to include which he feels as a clinically relevant pollen, and then prepare his solution and then keep it dilute. But then, having said that, there is a greater responsibility for the physician there, because he has to maintain that standard. So if you remember, they underwent a very big clinical training. The clinical training included their preparation of the allergen immunotherapy also. So in the initial classes, even when we have in DIA, sir used to take about allergy skin testing, but never used to venture on into the immunotherapy. So because the diluents all came from a standardized product in US. Now, shifting to this scenario, we go on to Europe. Okay, Europe was not very comfortable with using the subcutaneous immunoallergen. So they actually prepared a national and international regulatory guidelines, and the European Medical Agency was actually taking care of this. They did not want the subcutaneous immunotherapy and its complication and the preparation. So allergen immunotherapy was given to the manufacturers. They had the responsibility to have a standard one and they prepared in accordance, but each of the manufacturer had their own guidelines. And Yaki formulated the guidelines in 2021, only in 2021. So Europe still does not have a standardized, national standardized allergen, but each of the company has its own standardized preparation where the major allergens are clearly quantified. Now, the German-speaking companies like German, Austrian, Swiss, and Allergical Society, they have recently published a guideline document. And here, if you look at it, the basically a monotherapy one only. The manufacturers ensure the batch-to-batch consistency. They give an idea about what is the raw material, which CERT very clearly explain how are they extracted, the primary extract, what happens to the purified extract. Then they compare it with their in-house preparation. Then they submit their process to the US regulatory guidelines, which looks at their records and sees it is fine, and then they are given the authorization to do this. Here, there is no reference standards like in US. So their potency is established by in vitro IgE. Each of the company documents its potency about the same. They can extrapolate the data from one allergen to other. Now, in some cases, they may use a Nordic assay which uses a skin prick test or concentrate on wheel and uses it in comparison with histamine, which was already told by the earlier speakers. So if you can see this, the difference between the United States and Europe, which is major people who are following immunotherapy, and the parts of Europe which is associated with that where they practice immunotherapy. For example, in Brazil, they have the multi-system here. Here, the physician practices polyimmunotherapy, but they will get the products from the manufacturer. Whereas if you look at US, the manufacturer is referring to a US standard, whereas in Europe, each of the manufacturers have got their own standards. So it's sort of a mixed in some countries. Whereas if you look at US, it's like FDA approved. There is a Center of Biological Evaluation and Research. Though there is a European organization, there is a national competent authority, but the products are according to the manufacturer's authorization. So standardizations and non-standardized products are there. Here in Europe, you have the product-specific standardization of single products. There is a cross-product comparability based on the major allergen content in each of the preparation. But what is the standard they use? That is dependent on what they have prepared by the manufacturer. So here they have used a biological method. And as I said, in Europe, they use a Nordic, which is a percutaneous initial standardization, or the in vitro methods is also possible. So the potency determination is done by the Central for Biological Research. But whereas in Europe, if you look at it, the product specific standardization comes from in-house reference standard. So the potency units will vary depending on the manufacturer in Europe, whereas it is standardized in US. The labeling is also done by the US in comparison to the national standards, whereas in Europe, you use a manufacturer-specific units, and US Pharmacopoeia regulates the mixing in doctors' offices, whereas you should see in Europe, there is a monograph on allergen product, no mixing is allowed, by which we mean that you cannot practice polyimmunotherapy. It's only monotherapy. The European Medical Association clearly gives guideline on the specific manufacturer, the quality issues, how much to be used, and they specify the standards for this. So there is no formal guidance with regard to the clinical development in US, whereas there are a lot of guidelines with regard to the same in Europe. And the pediatric studies are being encouraged by the pediatric research centers, but whereas there is no actual pediatric studies here, but yes, pediatric development is moderated by the pediatric community separately. The skid formulation, the physician, or it is made up only in the allergen office, whereas in Europe, the allergen product is by the manufacturer. So you'll have to send in your physician detail, patient's detail, and then the product comes to you. So the number of allergens is multiple here, and it is aqueous and unglycerinated. But here in Europe, it is each company has its own, and it's only one product that comes in. It's aqueous, unmodified, and it is alum absorbed extract for SCIT. So SLIT is very, very less in US, whereas it is more in Europe. So this gives a very clear explanation of the difference between the SCIT formulation that's happening in the physician or allergist office, whereas it's in the manufacturers. The number of allergens is poly in Europe, whereas in US, whereas in Europe, if you see each of the allergens, you'll have to take it separately. Here, the potency unit. So this is a very clear graphical representation of what is happening in the world with reference to US and Europe, which are the major manufacturers, which are majority using immunotherapy. So coming down to us, what do we do? Before that, what happened? There was an internet when we really increased our exchange of knowledge, and when we really got. Now I understand why when PK Vedantan sir came, it was a different methodology of teaching. And when we went to Europe, it was a completely different methodology of treating. So even that could be with the international organization. So what they did, they thought, why don't we develop a standard product all over India, all over the world? So they created this CREATE project, wherein they actually involved a consortium of 9 research laboratories, 11 clinical centers, and then they actually produced the allergen production. They quantified the allergen either by mass spectroscopy or CD sequence. With all the things possible, they developed several recombinant allergens, and they had a biological reference unit. I mean, Nagendra sir already told about the recombinant allergen here. So that's why I said he laid the basis for what do I talk here. So they identified the ELISA reagents for allergen measurements. They specified criteria for allergen purity and all that. With all said and done, they could only create 2 recombinant allergen reference models, which could be used by entire international standard. So it is such difficult for us to do this. So the CREATE project also came up with a natural response curve of natural and recombinant allergen here. Now let's come to the Indian perspective. The first question we have is India ready actually for immunotherapy? Are we going to use then SCIT or the SLIT model? As we know, majority of us are with SLIT. Then we'll see what are the problems with coming to that being a majority. Are we going ahead only with keeping on very happy with the monotherapy, or are we going on to have a polyallergen because the situation may demand for us to use a polyallergens? Now, the standardization, which we have all talked about so much, how it really applies in the Indian perspective, and talking about the big money, which is the major driver of healthcare industry in India, is a question we have to answer. So in Indian allergy practice at all, we know that we are having a prevalence rate of ever-increasing asthma, about 3.6 to 4.5% in a different age group, and it's increasing for 6 to 9.5%. And there is a population attributable fractions which actually estimates the overall risk factor for specific burden of asthma. They said that we have actually an estimated 65 million cases, but most of these allergic cases are attributable to using of biofuels, kerosene, and cow dung cake. And this actually changed on to avoidable cases, which is amounting to 16 million and 11 million. Further, there was the environmental tobacco smoke. So here we are not talking about allergens for the preventable factors. We are talking about something which can be changed in the environment. Now, this was a very good study done by two people who really looked into the aeroallergen sensitization in Indian scenario. Very well known to us. One is from Dr. Saibal Mitra, the other is from Dr. Mahesh. And many of the speakers of this allergen immunotherapy were also involved as authors in this study. Now, they looked at what is the type of aeroallergen sensitization, and you could see that the aeroallergens are so varied between east, west, north, central, and south. And thanks to Dr. Neeraj's initiation, I was able to look into this in a much detail to create the pollen calendar. So this is actually the first step involved, because we know throughout India, if you can see, the dust mite had a predominant reason. And the instances of pollen allergen sensitization is varied here. So we have dust, but when it came down to pollens, the aeroallergen sensitization pattern is so varied in Indian scenario. So when we really have to talk about an immunotherapy, we'll have to take this into consideration. But before that, when we look at the prevalence and risk factors in Indian scenario, not any of these aeroallergens has been mentioned. The risk factors clearly mention each of this: asthma, allergic rhinitis, and atopic dermatitis are maternal smoking, paternal smoking, leading on to sedentariness, paracetamol intake, the outdoor pollutions, the damp areas, the birth weight, underweight, overweight, all came into factors, which led on to the odds ratio being more in favor of the disease process. Nowhere we have been mentioned about the aeroallergen sensitization or the sensitization that required a immunotherapy. So you can see the names that has been there, or one of the few people who are already pioneers in this. The Saibal's this was a very interesting article that looked into the review of aeroallergen-induced allergy in India. They found out there were 83 pollens, 34 fungi, and 19 insects. But they also found out that the genotyping for testing diseases actually had a major reason, which means they looked at not at immunotherapy as a future. They looked at targeted gene therapy as a future. And the same when you look at Mahesh sir's article also, you can see the aeroallergens formed a very small part. We have more of polymorphisms and the other environmental factors in there. So having said that, even the fact that we require immunotherapy in an Indian scenario is something questionable, because we will have patients who have environmental reasons, smoking and tobacco smoke. So even if you're going to give immunotherapy, will they be improving with this? Is first question we need more answers to. Now, there have been only 2 or 3 lectures that really told about the standardization practices of immunotherapy in India. Having followed this, one was again the Saibal Mitra and Samjadar, which looked at what is the amount of the prescription of allergen immunotherapy, where US had already standardized on the major allergen and also on the amount of immunotherapy to be given for each of us. And he was the one who published an Indian allergy immunotherapy guideline, where Saibal and Dr. Saibal Mitra and Samajhdar clearly said that it has to be given by a trained healthcare professionals and initiate immunotherapy based on a clinical evaluation. And they specified the disease wherein it is required, though it was very beautifully told by Dr. Deepthi on where it was required. They gave the duration of action and the allergen immunotherapy where and all it is contraindicated in Indian scenario. Having said that, what are the available companies, manufacturers in Indian scenario? I've not on any specific thing, I've put it from A to D. So you have the Alvac Pharmaceuticals, Alcure Pharma, Alcit India, Bioproducts, Credizol, and Merck Pharma. So these were the companies that came up. Some of them I know personally. Some of them I used the Google search, and this was the one that came up. So I didn't have any other. When you put immunotherapy for allergens, only these are the 5 or 7 companies that came up. Now, if you look at it, what was the collection of the source material? None of the companies had specified where they had collected, though there are here and there articles about how they collected their pollens, how they collected their fungi and the insects. The pollens are usually collected by what Sir had very beautifully described, though they have not specified in their website about the condition. The fungi usually, they got their raw products from Indian Agricultural Research Institute and IMTech and National Chandigarh Laboratory for this one. The insects, they actually, the dust mite and all, they had a very beautiful video on how they have cultured it. And they also showed the mites being cultured. They have videos, but their main site does not show what is the collection of source material. So we have a question with that collection of the source material here. But of course, CDSCO, which this is really Dr. Nagendra sir has told, that Central Drug Standard Control Organization took in this process of standardizing some of this, and then it had handed it over to National Institute of Biologicals. But Dr. Mahesh in a meeting told that how much of this standardization is known to the people who are working in NIB is still under questionable. But of course, they have given guidelines on what are the allergens. This is a way advancement compared to what was there in 2016 when we did that study. So if you can sit that here, they will be mentioning about the products, the brand name, you can see that they wanted a microbiological testing, sterility testing, which has been mentioned earlier about this, the relevance of the allergen for Indian patient, you need to show how much of this, and they had, whether it is a single allergen or a mixed allergen, has to give specification. So it's really a way, but we have to understand that it is from the manufacturer's own unit. So we are somewhere in near like Europe, where we have our own, where the manufacturers use their own products. Having said that, there is going to be the manufacturers use either a quantitative Bradford technique to be submitted to the board, or they use a qualitative gel electrophoresis, and by then they may use the weight by volume standard. So what it transfers into Indian is, we have to use only the same company for allergy skin testing. And if you're going to use them for the immunotherapy, the same company's product only can be used both for diagnosis and therapeutic. Having said that, how many of these companies are preparing the products? So we are, as something, mostly using SLIT. And we are not preparing it in our offices. We are relying on these companies to send us the products which are prepared for the patients. So SKIT is used only in certain centers, like maybe some centers wherein they're trained for preparing of the preparation for SKIT. They will get the base products and then they prepare. Again, in those centers, what is the base product they are getting? Are they getting it from these same manufacturers as a concentrated format, or are they getting it from US? Then, things change. Are they following our standards, or are they going to ahead with the US standard is something we don't know, because the centers which are practicing do not say where they are making the preparation. Studies are very few about that. What about the Credisol is one company that is actually giving ready-made products for the patients. That is, well, they manufacture only subcutaneous. But whereas we know Alvac, Allcure, all they have the sublingual immunotherapy. Now, to a new kid in the block is the Sensimune, which has come, that is Acarizax. This is almost clear to the European standards. So now we are stuck. Are we in which of the training we are going to have? So are we going to follow monotherapy? Are we going to use the company's product? Then if it's so, are we going to follow the European standards? Or are we going to follow the Europe? We are going to be a fellows and preparing here. And we all know that the first allergic education program was the Vallabhai Patel Chest Institute with New Delhi. We had the DAA at CMC Vellore, which came up in 2008. And most of you are very elite alumnus of DPAI by Dr. Neeraj and DAI from Cochin. But there is no 2-year fellowship training like US with hands-on training for us to prepare the sublingual subcutaneous immunotherapy in our office. So this is threadbare. I have to tell that. And then what about the finances which is involved? So when you take the Acarizax, we have something costing about 300 per day. How many of our patients are ready for it? And when we are asking them to come for about 2 to 3 years, is the patient ready to take it up that. So first, we have the manufacturer's issue of what they're coming. Second, we have the training level of us. So we are dependent on the training, on the products which are manufactured by them, and we are using it. We do not have the training to prepare it by using a concentration solution. Of course, we need specialized equipments for that. And the third, coming to the patient aspect, we have the finances and impact of this immunotherapy, asking them to come for an entire 3 to 5 years period, something which we do not know. And the psychological status and delivery of healthcare in Indian scenario is very variable. The patient might be highly motivated and go home to take up the immunotherapy, and then you will have a lot of patients a lot of relatives who are going to discourage him on that. And the delivery of healthcare is not uniform in Indian scenario. You have the physicians, you have the general practitioners, you have rural health workers, and the moment somebody goes and tells them about this immunotherapy, their response is going to be, we don't know, it can be varied unless until we create awareness that such a treatment exists. And then we have the added on the complementary alternative medicines like Ayurveda, yoga, acupuncture, aromatherapy, whatnot. So when we are going to counsel a patient on this, how are we going to actually, or rather, explain about the so many alternatives and tell us the advantage of what's going to happen with the immunotherapy? This was one very beautiful article, apart from the Dr. Saibal, which really gave the guidelines of allergen immunotherapy in India way back in 2009 by Gore et al. After that, I have not seen such a detailed allergen immunotherapy guidelines, but of course, Dr. Neeraj is making the guidelines for the same. I think it's high time we have this in. But we still have many unanswered questions. So are we going to stick with the slit and have the ready-made preparation coming from the manufacturers? If so, what about the conditions that require skit? Sorry, this was a typo. That is, say, example, like venom immunotherapy, which was much spoken about. Or in cases where people are more comfortable with using skit, what do we do in that condition? Because right now, the allergoids which came as a subcutaneous immunoproducts, we do not have the or products which are recombinant. So are we going to depend on them? Are we going to depend only on monotherapy, giving it for dust mite? And what do we do with the pollens? Should we give them separately? Are the guidelines for either the monotherapy or polytherapy ready with us? Will it be feasible even for us to go on to the polytherapy? If so, how do we manage the finances? Say, for example, for the sense immune treatment, if it's going to require, does the government is going to help us with that? How do we convince in patients in India where there is no follow-up record or the treatment to ask them to come here? We cannot even call them and ask them to come. The list goes on and on about the guidelines perspective of the Indian scenario. Yes, we have launched this guidelines together as a team. We are really working towards it. But I think we need a lot of conviction. We really understand where PAI comes from and Dr. Neeraj's conviction to start the standardization. But and also we need to make the government about this condition, make them aware about the need to help us. Like now, biologicals are available for certain cancer treatment. We need to make them aware that we really require sublingual immunotherapy, Sensimmune, for the people who are requiring. So there are a lot to go. The road is really long travel, but I think together as a team, we will be able to go through this. So this is my guidelines perspective on using the international standards here.
Thank you, ma'am, for this excellent session. It was truly informative, and you gave a very deep perspective on this topic. A lot of questions unanswered, as you told, and we are all going to learn together probably and create a change and create more awareness. And as we move on to a few questions, I think last couple of minutes are there. And as you told, regarding the problems associated, both of you, Madam Dikti ma'am, and you, both of you discussed what are the problems with the compliance and the associated with the long-term treatment. So, as per your experience, ma'am, what do you think? Where was the compliance better, with slit or skit? if you have.
The skit was
Yeah.
definitely better than skit. I have not even started skit. I told you, right? We were using allergoids when skit came because it was very easy for us to use. But once allergoids went off, how many of us are really using skit? More of us are very comfortable with slit. And the
Slit.
compliance is better. Then every month or every 3 months, when the new stock comes, it is a counseling session that goes on for 1.5 hours, telling them, yeah, you will improve, you will become better, take this medicines. I think Dr. Deepti very well understands this. Every session is a counseling session. Until now,
Correct.
all of us are very good with the slit only. And we have
Correct.
not
Compliance is
started.
definitely better with slit.
Yes,
100%. Skit with
100%.
those large local reactions, they tend to get afraid. They just reject it. They
Rejected.
fall off.
Allergoids, when
Yes.
it came, it was really a good thing. We were able to convince, we were able to do it. But the allergoids not being here is something which,
Okay. That was nice. Like that is what, but throughout the 3 years, like what kind of, I mean, roughly what percentage of patients have stuck on to completed the immunotherapy and as per your this one?
Okay. So I'll take that. For slit, 100% of the patients are following. Not a
Okay.
single dropout. Here, the importance of correct patient selection. Counseling
Correct.
them beforehand only. You're not going to see any magic. It will take time. It's not that you're not going to sneeze even once. Counsel them properly. Tell them pros and cons. 100%. With skit, my drop off rate is 80%.
Right.
I have to be very truthful. Our allergens are
Correct.
crude. Our skit allergens are crude. We are not using allergoids. They are using such specific allergens. Monotherapy is so specific. Their skit is far ahead of us. I think we are nowhere. And mine is almost, I can even say 100% drop off.
Correct.
Nobody has completed 3 years. I'm very bad at skit, but slit 100%.
Okay.
Sinchana, when I
Yeah.
went to UK, the skit, people following the skit therapy for insect venom, you have a whole team working on it. You have the nurses who are there. And the products are coming from the manufacturers for they purchase the whole products in several dilutions. And you have a system wherein each of the product is reviewed, checked by one, counter checked by other, and the people come on their time at 8 weeks, means 8 weeks. Now, this sort of a support system, we do not having it in SKIT. We
Correct.
cannot follow them. Here, the patients are ready to wait for everything else except for healthcare. Healthcare has to
Exactly.
come immediately, but that is not possible with us. And we do not have here everything is done by the doctor, right? From the starting, counseling them, giving the medicine, waiting for the thing, everything is done by us. How many
Correct.
of us who have the time for it? Because only relying on allergy practice, I don't think it is possible. We are doing a bit of pediatric practice and this only. So we do not have the support system, or we have not trained our paramedics for the same. So that's going to take a lot of our time. It's going to be a
Correct.
long way when you're going to get the complaints with regard to skit.
Exactly. And practically, how do you assure compliance in your practice, ma'am? Like any particular technology or anything which you have used, or is it through phone calls?
Only human technology. Rely on my secretary to call up and put up. That's another, nothing else. Have a diary. You follow the secretary, ask her to call up every day, I mean, every month for the particular patients. And that is one, is have a good record of those patients and then call them up. That is one that is help. I know some people, I think most of us will be doing the same
In
thing.
Do you?
US, UK, they have robust apps. We don't
Yes.
have. They remind them every day. They can even put their side effects on the apps. The app even decides what category of side effects. They have their questionnaire which they can put in the app. Here we don't have such robust app. Here we
Yeah.
or our secretaries are doing everything.
Correct.
Reminder, calling, everything. It's one to
Yeah.
one, but I think with proper counseling, they are sticking to slit. Even skit also. 80% of the time I've seen they falter after 1 year, 2 years. They start seeing the effect and they get fed up of coming again and again. The advantage of taking at home counseling, see if you leave in between, all your money will be wasted. All this, when we counsel properly, they are sticking to it. They come back.
Correct. Correct, ma'am. And in case of patients who get transferred, or in case like yesterday we were also discussing with the girl students who are going for boarding or something where they change. So how do you tackle this kind of issues in your practice?
I
So
think the
just now,
allergy asthma
yeah,
group is a
go
very,
ahead.
very good group, no? Wherein there are a lot of questions about who is
Yeah.
practicing there. I
Yeah.
think that way we connect
That
with each
is.
other and transfer.
Very well
Yeah.
said. Very well said. You should connect to our colleagues in
Our
that
colleagues.
particular city and we can refer. I'm being referred so many patients from all over the country when they come to Pune. The best part is now for house dust mite, we have slit tablets. So they don't
Correct.
need to be refrigerated. So even if children are going to the boarding schools, they can carry it. We can give
Carry.
them a couple of months tablets and they can keep it. So that is very good part. With drops, of course, we should refer them to our colleagues in various cities.
That's a very nice message with both of you have given, I guess. Yes, definitely. We have many allergy practitioners now across India and even globally. And many of us are already alumni of many courses or know each other well. So that could be one way of doing it. And also now the Sensi Immune tablets have come in, which require not don't require much of refrigeration. And this, so even people are carrying it abroad. They are finding it more. Reasonable to carry it from here rather than purchasing over there. So I think, and any role of markers, do you do any markers frequently or something to assure? I know it is difficult in our scenario because of financial
No, the problem is
constraints.
they're spending a lot in the other things. So I think
Yes.
clinical improvement is one thing which we can definitely know. Whatever the biological markers will tell, if the patient is going to tell that I'm still sneezing or I'm using the same nasal drops at a higher dosage, then we know that it has not been improved. So I think
So
clinical thing, asking them of how many vials they've already used for the thing, that will be more practically possible for us to.
Perfect.
yes,
Perfect, Dr. Narmada. Clinical. Let's be
yes.
truthful to ourselves. Who's doing IgG4? Is it available? Is it
It's
cost? What?
possible. It's
Yeah.
not.
Only
So
one
clinical.
problem, Ivan, what we come across is that patients keep asking that I want to reduce my IgE level. That is what they are behind.
It's going to take
So,
time.
So
We have to tell them
yeah,
6
no,
months
tell
takes.
them it will never come down. Tell them that
correct.
in the beginning, so that even if little bit it comes down,
They are
they are
happy.
happy. And one more thing, I always tell my patient never ever repeat IgE. Or if you want,
Exactly.
just repeat it every month and see it will be same or it will be increasing. We have to, we are treating you, we are not treating IgE. Make that very clear and make sure that they don't repeat it.
Dr. Deepthi, I don't even have problem with IgE. I have problem with skin testing. They want me to do the skin testing at the end of 6 months. That's what
Yes,
I'm saying. Anna, can we do it? They think it is like man to, even in tuberculosis, no, once we complete the treatment, they want proof that the treatment is completed either by X-ray or by man-to test. And we all know radiological clearance is going to take time. Man-to will not work. The same policy they want in allergy skin test. Do the allergy skin test and show me my child is not having the problem. How will I even show that?
Not
correct.
possible.
And what do you do for patients who leave treatment for like say 6 months to 1 year and then again come back? How should we restart it from the beginning or like how do we go about that?
So for slit tablets, now it's fine.
Hmm.
You can start it immediately. For skit, if you have left it for 1 year, everything is gone. Please don't start with the maintenance therapy. This is the problem where they have seen very severe systemic reactions. You have to again
Yeah.
start with the build-up phase. They might be having the same symptoms also again. In a year's time, if they have left after 6 months, 1 year, all the symptoms will come back. You have to start from scratch. And that has happened. In real life, that happens.
Okay. And for
Correct.
drops, yes.
Drops are, again sublingual. You can start with them. It's anyway, you're not supposed to do any build-up phase for drops. In India, we are following. In US, UK, nobody
Yeah.
follows that pattern. So you
Directly.
can start. Yes.
Yes, whatever maintenance, and we consider it as lost and then again restart for 3 years, back again from like it will be a new start basically. Yes. Only thing I was wondering was though we are speaking about standardization and so much, but our patients have done fairly well even on our indigenous. So, what is your comments on that? Like, I mean, though we
We
keep,
Indians are very resilient. We manage and handle everything. So that's good for us.
And another
Yeah.
thing, Sinchana, the only thing is we do not know the content of the major allergens. Apart from that, they are doing one work while they are actually standardizing among their own. They are also trying to, with a greater awareness, they are also trying us to give details about where we are preparing. Something is definitely going on. It is not like before. And so we actually we were thinking that we should redo the test which we did in 2016 to look at the biological equivalence of all the companies which are here. So we are planning for a study where we're looking at the dust standardization of the dust mate. I think central with all the allergen awareness, the companies have also come in. Having said that, as I told, how many of our Indians really require an immunotherapy with an good environment control, and that has also made a lot of difference into their control. So we have to individualize each cases and see the improvement of each patient here.
One last point I'll tell you, Dr. Sanchana, to your question.
Yes.
You are
Yeah.
telling we are doing good. How do you know? We are still on, there is immunotherapy is ongoing, so we are doing good. Have you seen? We are not even 10 years in immunotherapy. You don't know
Exactly.
after stopping immunotherapy, how will they
What
do,
really
good
happens?
they'll
We do
do.
not have any
That
studies.
is the biggest
Yeah, the
problem
relapse
we
rates.
don't have.
We
So
don't have
just now
studies
they
for
are doing
relapse
good.
rates.
Yes.
Actually,
So
we
we
should
could be in
actually,
trouble.
it's very
We could
easy
be in
now.
trouble. Yeah.
It's a very easy now because we are a small number of people who are doing immunotherapy. Actually, we can start a national registry among ourselves,
Correct.
and you can get a standard and see this as one of the cohort of people we can follow them up. But of course, adults they are already started for a very long time, but we do not have standards, so we'll have to coordinate with adult immunotherapy people also who are doing. So Dr. Saibal may be able to give a lead to it. But as a pediatricians, we can definitely have a very good registry for that, because pediatric allergy network is much more robust, I feel.
Yes. Okay, ma'am, that was an excellent discussion, and it was great hearing from stalwarts like both of you, and even Nagendra Prasad sir. And we had I'm sure there are a lot more good discussions which are going to happen as we progress. And thank you so much for all your insights into this topic. On behalf of the chapter, allergy chapter, I thank all the speakers, and it was great having you all, and looking forward to
Thank you.
hearing.
Thank you, Suchita. Thank
Good
you for the
night.
Thank you.
excellent work you and Dr. Neeraj are doing. It's really nice.
Thank you, ma'am.
Thank you.
Good
Thank you,
Thank you,
Dr.
Deepti, ma'am.